In doing this podcast, I have been shocked more than a few times by how little the medical establishment has studied women's bodies. I realize some of this neglect comes from the societal norms of the past. I get that. Women were considered to be delicate. No man would be seen as so crude to even consider seeing someone who wasn't their wife naked. It was indecent. And since women weren't, quote, smart enough to handle the rigors of a medical education, there were no women doctors to help out with this problem. But does the past and its ridiculous rules excuse the gaslighting that goes on in the doctor's offices of today? We're talking about endometriosis in this episode, and I have done a lot of reading. 10 to 15% of women suffer from this condition in the United States, which is the same percentage as people who suffer from diabetes. Why, then, is endometriosis not one of the first things doctors check for when women come see them with severe abdominal pain? So many women have to go through multiple doctors to get an endometriosis diagnosis. What makes endometriosis so difficult to diagnose? I'm ready. Let's get into it. We have Dr. Adam Kansagor, who is a DO, which to describe what a DO, not an MD.
So in America, we have two physicians that practice medicine. They
Okay.
do surgery, they prescribe medicine, all those things.
Uh-huh.
Osteopathic physicians are taught more of a holistic approach.
Is that what DO means?
It's Doctor of Osteopathic.
Got it. Okay.
So in addition to all the basic sciences that we learned in med school, we also got an extra 800 hours of hands-on, like muscle therapy, so like chiropractic stuff, massage therapy, physical therapy. And we integrate that into our practice.
Love that.
But yeah, most of the time you'll see a DO and MD and you really won't notice the difference.
Right.
But we all do the same thing. We all go to the same residencies. We all do surgery the same way.
Oh, interesting.
Yeah.
Well, you're an OB-GYN with Wake Med.
Correct.
Okay. And I love that idea that you have this musculature like specialty tied in with OB-GYN because you definitely need it for that. But anyway, we're talking about endometriosis today.
Sounds good.
And describe to everyone what endometriosis is.
So endometriosis is this multiple like symptom situation, and I'll kind of go with how it starts and kind of different ways that things happen.
Sure.
So in general, if you think about the uterus, it's kind of like a contained space.
Mm-hmm.
So I know if you're not watching me, you can't see me, but if I'm a uterus, these are the fallopian tubes.
Uh-huh.
The blood fills up every month. The lining gets nice and thick. And then when you're not pregnant, you basically shed your lining that goes out through the cervix, out the vagina. You have your period.
Exactly.
Sometimes some of that blood works its way out of the tubes.
Oh, so it goes up into the fallopian tubes.
Correct. And it pours out. And wherever it lands, it sets up shop.
Oh, and turns into lining.
Correct. Sort of. So like essentially, the lining of the uterus is meant to get thick and then shed. And this lining doesn't know how to do anything but that. So when it sets up shop outside of the uterus, like on the ovaries or on the bowel or on the bladder, it causes a lot of issues, inflammation, pain, things like that.
Does it shed?
Every time you have a cycle, it may sometimes have some bleeding.
So are you then internally bleeding?
You could have a little bit of bleeding sometimes, but like for example, if this stuff sets up shop on the ovary, it's like a contained little cyst, and every month it will start bleeding a little bit, and it kind of stays that way. So you have a contained little bubble of old sort of menstrual blood, but inside the ovary.
Oh, wow.
So when we see these surgically, when we open up these cysts, and we'll go into treatment later on, the blood is very old, so it looks very dark. And as doctors, we like to call everything food. So we call it chocolate cysts because it looks like chocolate syrup when it comes out.
Learning so much right now.
There
I
you go.
didn't know you guys like to call everything food.
Yeah, exactly.
I want to ask more questions about what other food analogies, but let's stay focused.
Fair enough. So like the most common form of endometriosis is that retrograde where it's kind of coming out. That's the most common theory. But we also have weird things where people will have endometriosis stuff outside of the pelvis. Like they could have it in their lungs, they could have it in their abdominal walls. It's all sorts of things.
Wow. So like in your torso on the, it just, so do you think that their fallopian tubes are like a sprinkler kind of like and just shooting it? Because I know we've learned on this podcast, and you learned in medical school that the fallopian tubes aren't stationary. They're not attached to one ovary, that they cross back and forth and they move around. So I mean, is that what happens? Is in transit, it just kind of showers it?
Sometimes that can happen. There's also theories that essentially some of that endometrial lining will basically go in the bloodstream, and the bloodstream will take it to wherever you go.
Oh, wow.
So like I've never seen this in my career, case reports where people will basically every month have respiratory issues because there's endometriosis in like their lungs.
Oh my God, that's
very
terrible.
not common.
Can it end up in your heart?
I'm sure it can, but
Because if
most
it's in
likely,
your bloodstream, you would think.
Yeah.
Oh my God.
And then the most common places I've seen it is in the pelvis, on the bowels, also in incisions. So let's say you have a C-section, and on the way out, some of the cells from the inside lining of the uterus, because you open up the uterus to get the baby out, if one of those sets up shop on the abdominal wall, it now grows like the rest of it does. So you may have like a mass on your abdominal wall that you have to get taken out.
So if you don't have like typical endometriosis and you have a C-section, some of that lining can get caught in the scar tissue, and then
Sometimes you can have
is
that.
it like a one case scenario, or are you developing into endometriosis at that point?
Endometriosis by definition is endometrial cells outside of the uterus.
Okay.
So
you had a case of it then.
Yeah. So those cases, you typically take them back for surgery and you take out that like ball of tissue and then they're good to go.
Okay. How interesting.
Yeah.
Are there stages of endometriosis? Like, like you have stage 1 cancer, stage 2 cancer. Is that the same with endometriosis?
Technically, yes, but let me clarify a little bit. So whenever we have endometriosis, the only way we could diagnose it is surgically. So surgically, we have to look inside the belly. We have to look inside the pelvis to kind of see where the inflammation is, where the scar tissue is, things like that. For us as surgeons to communicate with each other, we have guidelines as to what we see. So if I see a certain amount of endometriosis on the ovary and scar tissue here, a bunch of stuff here, a little bit of stuff here, we gauge it from, most of us use this criteria that's like 1 through 4. Okay. 4 being severe, 3 being moderate, 2, 1. This can dictate care in the future, but what's important to know is what we see when we stage it does not correlate with pain. So the reason I say this...
Oh, okay.
Yeah, like people could come in with chronic pain for years. We do a laparoscopy where we take a camera, look inside their abdomen.
Okay.
We see like 3 little tiny dots of endometriosis, and they have the worst pain in the world. And they're stage 1.
Because it's so the actual physicality of the cells is small.
Correct. So the staging is based on what we see, but it does not correlate with what the symptoms are.
And okay, couple of questions. Why do you have to cut someone open in order to diagnose this? Why, sounds like there could be some kind of a blood test or something, or perhaps, I'm not a medical person, so I don't know if there's like some kind of, you said you used a camera to look into somebody's abdominal cavity. Does that mean you had to do it surgically?
Correct.
Okay.
So endometriosis, most patients will typically have the most common symptoms, which is pain with cycles, pain with intercourse, pain with bowel movements, pain with urination, things like that. To actually diagnose endometriosis, you actually have to get a tissue sample. And the only way you could do that, if it's not outside of your body, and most of it is inside, is to do surgery.
Can it come outside your body? No.
Not typically.
But it can.
In very rare cases, yes.
Wow.
But most of the time, we basically will do an operative laparoscopy where we put a small incision in your belly button, and then we take a camera, look inside, and we kind of look around and see stuff, and then we take off biopsies. A lot of people want testing. They want blood work. They want ultrasounds.
Well, if they're in pain, you can't blame them.
Correct. So ultrasounds, CAT scans, MRIs, these are all good modalities to help find endometriosis sometimes. So if you see a large mass of endometriosis, you can see it with an ultrasound. It's an easy diagnosis when you have a larger mass, or if you have a mass on the bowel or things like that. Also, people come in with like kidney stones or something, and they get a big image and they say, "What is this thing?" It looks like endometriosis. But to truly get the definition, you need to have like someone take a piece off, send it to a pathologist. They look at it under a microscope and they say, "Hey, this looks like the stuff that's supposed to be in the endometrium or inside the uterus, and it is not there."
Interesting. Can you, when you're looking at these images on like a MRI and whatnot, does it sometimes look like cancer? Is that part of the reason why you have to get, like, you can't visually do it?
It doesn't cancer looks in lots of different ways. So like whenever there's anything suspicious, radiologists will often say further imaging warranted, you should do exploration, things like that. Endometriosis is not usually associated with cancer. Like endometriosis and cancer is like less than 1%. So
That's great.
So I don't want anybody to think if I have endometriosis, I have
You're
cancer.
predisposed to getting that. Yeah. But it does kind of act because it grows crazy like a cancer cell does.
Yeah.
How weird.
And then wherever it sets up shop, it causes inflammation and it causes infertility, it causes scarring, it causes pain.
Yeah, and that's what I was going to ask. That's my next question. So if you have, this person's in an immense amount of pain and, but they yet have stage 1 because they only have like these 3 little tiny pockets of endometriosis. Why is it so painful?
Yeah, endometriosis it's a combination of big picture stuff, hormones impacting cells causing inflammation.
Okay.
Inflammation on location equals pain.
Right.
So every month that you ovulate, every month that your body goes through the normal spikes of hormones, it basically is feeding the endometriosis and causing it to get, quote unquote, I tell them like angry.
Yeah.
And then angry causes inflammation. And if you have inflammation next to your like the back part of your vagina, sex is going to be terribly painful.
Yeah.
If you have that inflammation on your bowels, having a bowel movement is going to be very painful.
What exactly causes endometriosis?
So there's not actually like a known genetic disposition. Like there are some people say it runs in my family. Like there is some risk factors for it, but like risk factors for endometriosis are really varied. There's not like I ate this, I did this happens. It's just you're usually born with it and these cells happen. Things that predispose you to endometriosis is long periods of estrogen exposure, which means if you think about before you hit puberty, you didn't really have estrogen going crazy because your ovaries weren't working yet.
Okay.
Let's say you hit puberty at the age of 7 and then you went through menopause at the age of like 58. Your body has been exposed to estrogen so much longer than someone that started their period when they were like 13 and they went through menopause at like 45.
Okay, but you're saying you're born with it. Like if you're born with it, you weren't exposed to it prior, or does
Correct.
it have something to do with when your mom was pregnant with you?
Not usually.
Not usually.
Yeah.
So when you're saying that you have this exposure to estrogen from 12 to 45 or whatever, and then versus someone from 7 to 54. So is it common to develop endometriosis as you get older?
It's most commonly found in the reproductive ages. So essentially, like I have friends from college that I know before I went to med school that they're like, oh, I have endometriosis. I had to have surgery when I was 14. And I just kind of put that in the back of my head, not realizing years later, I'm like, oh man, they had so much pain that they tried conservative therapy, they tried medications, and they had to have surgery. Most endometriosis affects like about 10 to 15% of the population.
That's a big percentage. That's the same amount as diabetes.
Yeah, it's pretty huge. And if you look at all women, 10, let's say 10% of the population, a lot of times we find it when people come in for pelvic pain or infertility. So people that are having infertility issues, about 50% of those people wind up having endometriosis. People that have pelvic pain, chronic pelvic pain, they're upwards in the order of like 70%.
70?
70.
Well, this brings me to another point. I wasn't going to get this to later, but I mean, you just kind of stepped in it. You stepped into it.
You're welcome.
So you're saying that this is a very wide swath of women who have this. Why is it then that it's so underdiagnosed?
Because so many of the symptoms are so vague. So you could have painful periods just because your periods happen to be heavy. You could have bloating, diarrhea, constipation because you have irritable bowel. You could have bladder pain because you have a UTI. There's so many things that can mimic these things that it's really hard to diagnose. And again, most of the time when you have symptoms, you go to your provider and they give you something to fix the symptoms. So you're kind of masking the situation.
I see.
So if you were like 14 and your first couple periods were miserable and then you're on continuous birth control for
Which is what happened to me as a kid.
There you go. For like the next 15 years and then you decide to have babies, your body we have been messing with your hormones for 15 years because we've been stopping you from ovulating.
Oh, okay.
So you've not really had a chance for that endometriosis to flare up.
Oh, okay.
And then when you come off of hormones, then it's like, oh, I've been here the whole time and I was waiting, and it could come back like that.
Oh, interesting. Well, I've known a few people with endometriosis. One of the women who works on this show has it, and she said she took like 5 or 6 doctors to diagnose her because no one ever believed her. Have you heard any of this from your patients?
All the time.
And what do you have to say to that?
A lot of times I get people as the 3rd or 4th consult, and when I go through all of my differential, they're like, nobody's ever asked me that before. Nobody's ever gotten me there. And a lot of times you just treat the symptoms, and they don't want to put people at risk of surgery and complications to make the diagnosis, because if your periods are controlled with just birth control, you should be okay for a little bit.
Right.
So you may not be diagnosed because they're masking the symptoms.
Right. Is there danger in that, or not really? It just isn't going to happen until you come off those birth control pills.
Not really danger in it, but you're not,
You're not fixing it.
Right. And the big issue that we have is whenever we treat someone with endometriosis, we want to treat, like I ask people, where are we at? Do we want to make babies anytime soon, or we don't want to make babies? Because if you don't want to make babies, there's a whole lot more options.
Okay.
If you are still, considering making kids at one point, there's a lot of things that we can give you, but almost all of the medications that we use for endometriosis are hormonal, and they suppress stuff.
Yeah, they don't want you to ovulate.
Right.
Right. That makes sense, given that's when all this stuff tends to happen.
Mm-hmm.
So what are the treatments for it?
So treatments typically for someone that has like mild symptoms would be anti-inflammatories, so like Motrin, Toradol, things like that are just pills that stop the inflammation, because we talked about pain comes from that.
Sure.
And hormonal suppression, so either continuous birth control pills or cyclic birth control pills, where you have a period every month.
Mm-hmm.
And whenever we talk about birth control, we have progesterone, and then we have estrogen and progesterone.
Mm-hmm.
Those are the 2 main categories of medications.
Okay.
They both work in similar ways of suppressing that spike.
Okay.
But they all have different side effects and complications.
Okay.
Progesterone only ones usually cause like weight gain, depression, things like that. So
Fabulous.
You're already having a hard time. Let's just sprinkle on some sadness on there.
Let's make you a little chubbier so the fat bias can work on you and make you, tired and irritable. Go ahead.
And then, yeah, I mean, it's like one of the joys of you guys being you guys. Like, there's nothing fun about it.
I appreciate your empathy.
Yeah. Like I'm the only male in my practice, and I live with, 2 girls and my mother-in-law and my wife. Like I'm surrounded by women all the time.
You were born to do this.
Apparently.
Okay, good.
But it sucks to be you guys as far as hormonal wise.
Oh, it's terrible. We have no control, and we don't even know what's happening. Anyway,
yeah.
What about the estrogen and progesterone ones?
Got it. So these medications just kind of suppress ovulation. They suppress that estrogen spike. Big picture stuff, you want to go to the source that's causing those hormonal spikes. Mm-hmm. And we also have more sophisticated medications, if you want, that are more specific, and they work higher up on your hormone chain. They actually work on like your pituitary, and they kind of block hormone production.
Oh, wow.
And these are great medications for endometriosis. They're also used for breast cancer. They're also used for prostate cancer because they're blocking hormones.
And hormones cause these types of cancers.
Correct. And then what those drugs do is they basically put you through temporary menopause. So if you weren't having a fun enough time at 25 with pelvic pain, let's sprinkle on some menopause on there. But the benefit of that is it really suppresses the hormones. The downside is you have hot flashes, vaginal dryness.
Not always. I've learned.
Not always.
But you're prime for it.
Correct.
Yeah.
And then like decreased sex drive, all the things that help you are going to be kind of suppressed.
Yeah.
And you can't use those forever. Like there's several on the market, and some of them you could use for 6 months. None of them are they FDA approved longer than 2 years.
Oh, why? Because there's not been testing, or?
Because whenever I turn off your ovaries, I put you at risk of osteoporosis. I also put you at risk of heart disease. Like the reason that women and men have heart disease issues, women later on in life, is because estrogen's protective for you guys.
I see.
So if I turn it off, I could give you osteoporosis and can cause major complications in the future.
So this is a really hard thing to control. Yeah. And speaking of menopause, whenever your ovaries are, essentially like, peace out, I'm done, know, does endometriosis continue, or is it much less, or what happens?
Most often endometriosis kind of slows down towards the end of your fertility time because your hormone levels go down.
Okay.
About 2 to 5% of menopausal women will still have endometriosis symptoms.
Okay.
And it's kind of the chicken or the egg, because a lot of times you get put on hormones when you're menopausal to help with hot flashes. Yeah. So you were tailing down with the estrogen, and then you get estrogen given back to you.
Yeah.
So that could sometimes cause those flares. Most often it's because of the scar tissue, the damage, the things that endometriosis did to you years ago can cause pain in the future because the scar tissue is still there.
So how does it scar?
Again, if you have inflammation, when this is inflamed and this is inflamed, they kind of stick together.
Oh.
So a lot of times you'll have the uterus and the ovaries and the tubes, they're all supposed to be mobile.
Okay.
Right? When I've had really bad endometriosis cases that I've taken back surgically, you cannot separate the uterus from the bowel, from the colon, from the sidewalls. It's like someone poured concrete in there.
Oh my gosh.
And everything's scarred together.
And so you can't break up that scar tissue?
You do. It just takes a very long time, and you have to be very careful because of the risk of bowel injury.
Oh my God.
That's where there's benefit in like robotic surgery, because you have tools that can help you articulate your instruments pretty well. So you can actually get really, really close down to like the very, very deep
edge
levels.
Of the, edge of the organs.
Right. And in general, when we're talking surgery with endometriosis, there's a couple schools of thought. One is ablation, which means you burn it, zap it, you see it, and you just burn it.
Wouldn't that leave scar tissue?
It does, but it kills the endometriosis.
Okay.
A lot of us just do excision. So we find the endometriosis and we kind of remove it, like we cut like a little circle around it. And I describe it to my patients like, let's say you have a paintbrush and you dip it in paint and you just go like this. And you just spray it all over the abdomen.
Right.
You will see little dots everywhere. And it's sometimes hard to see. So we do different tests to basically light up the pelvis so we could find those little spots. And if they're on the ovaries, we sometimes remove the cyst off of it. If it's really bad, we sometimes take the ovary out completely.
Yeah, my mother had endometriosis, and she had a full hysterectomy. And is that common still? I think from what I've read, hysterectomies are less common nowadays.
Hysterectomies are less common nowadays. It is still very common for pelvic pain, endometriosis. If you have endometriosis, pelvic pain, and you're done with childbearing, hysterectomy. And just to clarify, hysterectomy means uterus. Doesn't mean taking out your ovaries.
She had her ovaries taken out too. What is that called?
So that's technically an oophorectomy. But
an oophorectomy.
Yes.
Oh, okay.
When people say I had a partial hysterectomy, usually in the lingo, if someone had a partial, that means they just had their uterus out.
I see. And that's in fact what is defined as a hysterectomy.
Correct.
Gotcha.
And a total hysterectomy is typically the ovaries, the fallopian tubes, the cervix.
That's what she had taken out. Yeah. So, but it makes sense because that's the problem makers. And so the endometriosis was awful. It was over rather. So I know we're backtracking a little bit, but let's just, what are the clear symptoms that you might have endometriosis?
Textbook is, there's never textbook, but most common is pain right before your cycle, very painful cycles, heavy cycles. Pain with intercourse is a big one, especially on deep. So, basically, endometriosis is in the back of the vagina. And just to clarify, the vagina is the hallway.
Yes.
The outside is the vulva.
Yes, yes.
Thank you. At the end of the hallway is a cervix.
So you need to be talking to like a group of men about this.
There you go.
Just so you know.
I'm like, this is what we have. It's called the baby hallway. So at the end of that hallway is the cervix, and that's held down by some ligaments.
Okay.
A lot of times endometriosis sets up shop there, which makes sex very uncomfortable, especially in certain positions.
I see.
Pain with bowel movements, those are the most common. And infertility is usually the first main sign of endometriosis.
And what are some of the unusual symptoms of endometriosis?
Some of those weird ones as far as like cyclic diarrhea that comes with your periods. I've seen in my career people that have basically very heavy period blood that comes out of their rectum during their cycle. Oh,
God.
Because the endometriosis set up shop in the colon.
Yeah.
I've only seen that once in my career.
Poor girl.
Some of those weird extra areas, but most of the time it's the typical pelvic stuff.
Yeah, so like if you you mentioned that it can get in your bloodstream and you can have pain like in your lungs and stuff. I mean, how are you going to know it's endometriosis versus something else, you know?
Most of the time you've gone to an academic center and they're like, this doesn't make sense. Why are you coughing up blood every month? This is weird. And then someone will perk up their head and they're like, this is that weird zebra case, you know?
Yeah, yeah. And when do you know that your symptoms are serious enough to see a doctor?
Essentially, quality of life. You know, we know that there's a difference between painful periods and painful periods that prevent you from going to work and school. That's usually like the criteria. Quality of life, if you're constantly in pain, if your sex is so painful for you that you're like avoiding it.
Yeah.
Infertility, all of these things are reasons to come to speak to someone to see about treatment wise.
Okay. All right. So I'm going to pepper in some listener questions,
Sure.
and we get them via our website. It's in the show notes if you have any questions. So the first one is, when I was first trying to be diagnosed, I was having periods 2 to 3 times a month, but it wasn't always the same. Sometimes it was bleeding, but other times it looked like different kinds of discharge. How can someone with endometriosis tell the difference between a flare-up and their cycle?
Okay. So cycle abnormalities are not always endometriosis. Okay. So if your periods are irregular, that's a lot of times related to other things like polycystic ovaries, where your hormones are not kind of doing their job in a proper way that you would have a regular cycle.
Yeah.
Kind of analogy I give is essentially you have the uterus and you have estrogen and progesterone. Estrogen makes the grass grow. So you have long grass. Progesterone is the lawnmower, mows the grass. Your lawn clippings come out. That's your period.
Gotcha.
You can imagine if you don't mow your grass for like 3 months, when you mow that grass, there's going to be
heavy.
It's going to be heavy. There's going to be weeds, all sorts of bad things.
Yeah.
And your uterus has to squish out this blood.
Yeah.
And that can be very painful. Endometriosis typically causes pain a couple of days before your cycle. It's usually very painful during your cycle. And you may have bleeding after you expect it to because of its location inside the uterus.
Yeah.
And sometimes there's something called adenomyosis, which is basically, the old thought was endometriosis that basically went into the muscle of the uterus. So again, if we're in the room and the wall is the muscle of the uterus, the wall will typically get thicker, and then this lining will shed and go out the front door or the cervix. Sometimes it goes into the drywall and impacts the uterus, and that's why it causes pain and irregular cycles.
I was getting ready to ask you that. I was like, inside the uterus where it's supposed to be, how is that causing pain? But that makes sense. Is it embeds
it's going
itself.
into the muscle. Yeah.
Yikes. Okay. All right. So the next question is, when I have an endo flare-up, I can be so bloated, inflamed, and it looks like I'm pregnant. What are a typical full body response to, and what are the typical full body responses to endometriosis?
Endometriosis, typical like GI things is bloating can happen, constipation, diarrhea. Full body stuff is usually just pain, depressive symptoms, anxiety.
And why is the anxiety and depression a part of it? How does it affect that?
Mostly because you know you're going to be in pain.
Yeah.
And you know that this time of month it's going to be terrible, and it just causes so much
You're stressed
issues.
out about it.
Right.
Yeah, which also it can exacerbate the diarrhea side and all the other things. Last one for now is, sometimes when I have sex, I start bleeding during or after, and it feels like that triggers an endo flare up, or I have an early period. How does endometriosis impact sex?
Anytime that you have bleeding after sex, you should always go talk to a doctor about that.
Always.
Or a provider. Because most of the time it's nothing to worry about, but it could be a sign of cervical cancer. And if this person hasn't had a PAP in good time, you want to make sure that's there.
Okay.
Most of the time it can be treated with hormones, not a big deal. Endometriosis causes pain with intercourse based on where it's located at and the positions in which you have sex. Endometriosis doesn't necessarily having sex is not going to randomly trigger you to have a period. Those aren't the same.
They don't work. Yeah, that's
not the same thing. But a lot of times when people have sex with pain because of endometriosis, it's because the penis or the toy or the finger basically reaches the back end of the wall. So for patients like that, we actually would recommend some things to help them not go as deep.
Yeah.
So there's like a device. It's called an OH nut
Okay.
Unless it's inappropriate, but
Yeah.
whatever.
Oh, it doesn't matter.
And they're basically a bunch of like silicone rings that stack on top of each other. So if you remember, if you've had toddlers, you have that ring toss game.
Yeah. That makes total sense.
So you have that
Makes the penis shorter.
way shorter.
Yeah.
So you could still have as much force as you want, but you're not actually hitting the back end of the wall.
Oh, interesting. So that's helpful. Is there a cure at this point for endometriosis?
Cure, mostly it's just treatment basis, and hysterectomy, taking out your ovaries, that is often said as the way to fix endometriosis forever.
Yeah.
But cure is not necessarily going to always happen. But I could tell you that I have done multiple surgeries on patients. I've given them conservative medicine. I've taken out one ovary. I've taken out the other ovary. I've taken out their uterus. And eventually the final thing that made them better was when all of their female organs were removed and they had to go back on hormone therapy.
Oh my God.
And some of these women are in their late 20s, early 30s.
Oh, and so like they have to adopt if they want to have kids.
Yeah. So we do everything we can to avoid measures like that.
Yeah.
So
It's very invasive.
Yeah. So a lot of times we could just remove as much endometriosis as we can, and we try and fix the situation that we can.
Okay. All right. We've covered a lot of my other questions here, so let's just go into a few more listener questions. My mom had an ablation to treat her endo. It pushed her into menopause at the age of 39. What are the implications of endometriosis treatments, and how could they affect us long term?
Okay. So I don't think she'd have an ablation for endometriosis because that doesn't correlate. So
You said it earlier.
ablation inside the uterus, that's what they're talking about.
It just says my mom had an ablation to treat her endo. It pushed her into menopause at the age of 39.
Okay. So ablation inside the abdomen. So if I'm looking at the ovaries and I see endometriosis, I can zap that or do an ablation.
But you wouldn't do it inside a uterus.
Correct. I thought usually when we say ablation, it's inside the uterus, and we do that for heavy bleeding, where we basically burn the grass seed.
Okay.
How did it cause early menopause?
Yeah.
Let's say in her situation, there was a lot of endometriosis on that ovary, and that surgeon was very aggressive in burning that ovary. If you cut off the blood supply to that ovary, then you would kill that ovary and go through menopause.
I see.
Typically, when we do ablation of endometriosis, it's kind of like spots.
Okay.
So it's not usually one that would put you in menopause.
Okay. The next question is, there is an Instagram account called Meals She Eats. Meals-she-eats. And this is with a couple who turned to balancing their hormones through diet to treat their PCOS. Are there ways to change your diet to help with endometriosis? And can a certain diet make your symptoms better?
Got it. So I could tell you from an evidence-based point of view, we're trying to avoid things that cause inflammation. We have tried to find an actual diet that legitimately changes endometriosis, and there's really not much data out there. But when you look at, I know there's a book that's like the endometriosis diet, it's like a 4-week thing. All of these things are all about clean eating. It's just like the 30, like the clean 30.
Yeah,
it's all talking
Whole
about
30, yeah.
Essentially, you want to avoid things that cause inflammation, and you want to use things that are high in omega-3 fatty acids.
Why do they matter?
Because those theoretically stop inflammation.
Okay, theoretically, huh?
Theoretically. And anybody that's ever been on one of these diets will always feel better. The problem with these is if I tell you you have a month to fix your life with this diet and you do everything and you're so proud of what you're doing for that month, I 100% guarantee you're going to feel better because you've done so much for yourself.
Sure.
They don't really do random trials where you say you're going to eat this fake meal and then you're going to eat this healthy meal.
Yeah.
Let's compare the two.
Yeah.
But I do know that if you have high antioxidant foods and if you do have things that help with inflammation, like all of the things that the Mediterranean diet have, olive oil, exercise, fish, all of these things, plant-based diets, all of these things can help. The downside is sometimes a lot of plant-based diets have a lot of soy in them, and soy can mimic estrogen sometimes. And if you have too much soy, there is sometimes people that get worse with it.
Because you're giving your body more estrogen.
Correct.
I heard I've read into a lot of this stuff with soy, and that it's when you mess with the soy. It's not like if you eat a soybean, you should be okay. But if you have like soy milk
And you process it,
and you process it, that's when it really starts to take change, you know? Okay.
There's a lot of things with food that change, like even how you cook food. Like if you use olive oil but you use high heat versus low heat, high heat kind of ruins all of the benefits and it changes the structure of the fatty stuff.
Yeah,
So,
which is why we cook, to change the form of the food. I was told if I want kids, I should have them before 28 because of my endometriosis. Why is that?
I don't know why 28. I mean, there's not...
That's what this parent doctor told her that. Yeah.
I mean, if you have really bad endometriosis and most of our treatment options are going to put you into menopause or they're going to stop your inhibition, you don't want to be doing that when you're in your mid to late 30s because it could impact when you're going to start having babies again. Can
endometriosis affect a pregnancy while you're pregnant?
Not usually.
Okay.
So endometriosis will definitely impact getting pregnant, but once you are pregnant, most of the time people actually feel wonderful and they actually don't have any symptoms of endometriosis while they're pregnant.
Oh, that's awesome.
And then once they are delivered and they are unpregnant, they go back to where they were before.
And they're like, damn it, I don't want to have 35 kids, but I would to keep the pain down.
Yeah. I don't know about the 28, but I would say that have a baby whenever you feel like you are ready to. The 35 that everybody talks about, the advanced maternal age or the elderly pregnancy.
Yes, I was 38. I was a geriatric pregnancy.
Yes. I will never call someone geriatric.
Thank you. Thank you so much.
You could be 85 in my office. I'm not going to call you geriatric. But like in general, it is harder to get pregnant the further along you are in your ovulation because the quality of your eggs can go down at some point.
Sure, they get old.
Right. And any time we do any treatment that could impact ovulation, we could impact the egg supply.
Gotcha.
Conversely, if you have a big mass on your ovary that's from endometriosis or an endometrioma, and we take it out, we are taking sometimes part of the ovary out, and you're taking part of those eggs with it.
So it's just going to be harder to get pregnant when you have endometriosis.
Correct.
I see. How does stress impact endometriosis, and can it cause flare-ups?
Stress absolutely can, because you have like a fight or flight response, and whenever you have a fight or flight response, you have anxiety, which causes everything to be heightened. We also know that things that reduce stress, like exercise, yoga, acupuncture, these things can actually help improve endometriosis.
Because it reduces the stress. And like cortisol, does that cause inflammation? Because cortisol is the stress hormone.
Right. It causes inflammation. It causes anxiety too.
I see. All right. Well, last little set of questions. And it's basically, I'm going to go back to the fact that so many people have to go through like so many doctors just to get someone to say the word endometriosis. It still blows my mind. You know, what's the most effective way to advocate for yourself when it comes to endometriosis? You know, like if you feel like, I don't have IBS, you know, we had one person tell us that they said that her uterus was just too small to have a period. That like a doctor said this to her and she was like, I don't think that's right.
That doesn't sound right.
It doesn't make sense, you know, but there are so many of these doctors out there gaslighting women when it comes to endometriosis. So help them. You're a male doctor, which is a perfect person to say, this is something that I think that would make a male possibly believe you, because the gaslighting is real with endometriosis.
Yeah. I mean, I could tell you from like personal experience, my sister-in-law is 31 and she was gaslighted by, and I hate to say it, but I was like an old white guy. I'm like, yeah. Old white guy.
Oh yeah.
And I was like, and I got her in touch with, a colleague that I knew where she was living, and I was like, she's going to listen to you. You're going to do whatever.
She's going to listen to you.
Exactly. But I'm like, this is how you advocate for yourself. So the best situation that I have is someone shows up to me and they say, this is what I've been doing. This is what I've tried. This is sometimes you call it a pain journal, where you basically log when are you worst during your cycle. And there's 1,000 apps with ovulation.
Okay.
Tell us what made it better, what made it worse. Ability to try medications and see if they don't work, and also the ability to know that surgery is sometimes needed to help diagnose things.
Yeah.
We don't go in just guns blazing just to go into surgery for that.
Yeah.
But advocate for yourself, saying that this is how it's impacted my quality of life.
Yeah. If
I had to say the most troublesome things of these symptoms, A, B, C, and D, these are the ones that are impacting my life so much.
Yeah.
And if you're not satisfied with the doctor that you have, there's a lot of them.
Yeah.
And you have a right to advocate for yourself.
Yeah.
And there's too many people. And prior to being here, I was in Eastern North Carolina and I was in academics at ECU. And we had all of these little healthcare deserts. So you have like,
oh, yeah.
you have one doctor that's been there for forever.
Yeah, like why are you going to move to the middle of the country when I can be a doctor and live in a big city or by the ocean?
Correct.
Yeah.
So a lot of times people just go to that one person and they say, okay, this is what it is.
Yeah,
And
because we've been taught to listen to our doctors.
right. And then the best thing you could do is come to our office, and if this is the first time, be clear with your symptoms. If this is your second or third time, give us access to all of your other records, because I love when I have someone that has done all of the things that I would normally do, and now I have to do this.
Yeah.
Because I know that someone else has been practicing evidence-based medicine and it wasn't working for them.
Yeah. So again, you're not the first doctor to say advocate for yourself. If you feel like it's wrong, then keep trying. You know your body better than anybody else.
Yeah.
So, well, I appreciate your time today.
No problem.
This was really, really informative, and we may be asking you to come back if we have more questions about this. But it's really good to know there's a doctor like you out there.
Oh.
You're an awesome. Yeah, I can tell you're an awesome doctor.
Well, thanks for having me out, and I'm happy that you're doing this, and it's really cool to watch like my colleagues and stuff talk about stuff and exposing it out there.
Yeah.
So at least someone that hears this is like, oh, that's actually me.
Yeah, that's what we're hoping.
Through.
That's what we're hoping. All right, well, take care. Thank you so much. What a complicated condition. And again, we hear advocate for yourself. If you feel like your doctor isn't listening to you or taking you seriously, get another doctor. Periods should not be severely painful. Take care of yourselves. No one knows you better than you. To share your thoughts on this episode or to send me a question for a future episode, go to WRAL.FM/Sarah Has Questions. The link is also in our show notes, by the way. Sarah Has Questions is a production of Capital Broadcasting Company. My guest today was Dr. Adam Kansagor, a OB-GYN with WakeMed. To find out more about him or any of the other providers with the WakeMed team, go to wakemed.org. Thanks for listening.